Hello, and welcome to our webinar, Adapting in a COVID World, PT Experiences Across the Spectrum. My name is Tim Lohr. I'm a graduate of the CU Physical Therapy program. I'm also president of the Alumni Association here at CU. It is my pleasure to be able to welcome you all here tonight for what should be a great panel discussion. I'd like to start off with a brief introduction from our program director, Dr. Michael Harrislove. Michael?
All right, great. Thanks a lot, Tim. So again, just want to welcome everybody to this webinar today. It's a critical topic. It couldn't come at a more important time. And we're really excited about the panel that we have lined up for you today. Just want to try to put the talk today into context as we move forward. And so one thing to think about, I think, is what would be the story of COVID-19 when it's all said and done, or at least into the next global challenge. And so just some things for us to think about. Clearly, we have a loss of life and damaged institutions that have occurred secondary to COVID-19. And beyond that, the loss that we've had of human relations, of seeing our graduates walk across stage, of having family gatherings, if you will. So this is the thing that we first think of. But I think another thing to keep in mind is really the cracks or the fissures that COVID revealed. Vulnerable institutions that are really built upon structures that are not sustainable in the long term. And I think notably, we think about the payment structure in terms of our medical systems and how we have caps and cuts to physical therapy, which imperils the access to our care. We can also talk about the educational system and ways that we've been impacted by COVID as well. So these have shown us areas that were always vulnerable from the beginning. I think when you look at this recent talk by Scott Galloway, where he was mentioning some of the threats to education and health system, keep in mind that the Common Research University is kind of rooted into a model from 1876. And so oftentimes we're linked to those traditions and not really meeting the needs of the new learner. Likewise, when we think about healthcare, it's also subject to disruption. And so in thinking about our access to telerehab and telemedicine, even within our own state, physical therapists have made inroads to have a higher utilization of these services, thanks to the advocacy of many practitioners in our area. And so when we talk about the disruption secondary to COVID-19, education and healthcare are key areas for us to watch. So recently I came across a study in the Daily Beast, which featured one of our alum, Kyle Ridgway, really talking about his interaction with patients and with COVID and managing this patient population in the hospital. And that story really prompted me to think about a dialogue with fellow practitioners and educators about what's truly essential and thinking about physical therapy as representing a new essentialism in our medical practice. I mean, after all, if we consider the issue of keeping our census in the hospitals low by keeping patients mobile, shouldn't that be considered essential? Or if we talk about the chronic conditions that will follow COVID, certainly that's essential. So when we think about really what has been wrought by COVID and the nature of the conditions that we're treating, PT has to be considered as an essential element of medical care. So as we consider the things that we might want to reflect upon as we go through this seminar and think about what we need to do to adapt in a COVID world, let's ask ourselves a question: who is essential? And do we have an opportunity now really to highlight the value of physical therapy? Should we consider access and how tele-rehab should be used or not used depending on our clinical circumstance and environment? And then also thinking about us being proactive rather than reactive. What opportunities can we really capture to promote physical therapy and make sure that we remain an essential piece of the puzzle in terms of medical care, both during the age of COVID and beyond? And so in reflecting on our panel that we have today, it's my hope that Ridgway, Lee, Horsfield, and Schramm can help navigate the difficult road that we have ahead and give us some context based on their experience as clinicians, educators, and administrators. We welcome your questions and your engagement as we go through this seminar today. And again, we thank you for participating. Tim?
Thank you, Michael. To provide a little bit of structure of how this is going to be laid out, initially what I will do is I will provide an opportunity for each one of our panelists to provide a brief introduction and background prior to going into the Q&A portion, which will take up a majority of our time. As Michael alluded to, we would appreciate any engagement and questions, and we would refer you to use the chat functionality within the Zoom call to input any questions that you do have at any point in time during the discussion. We have individuals monitoring this, and we will try to get to all of your questions as time allows. So without further ado, I will pass it over to Kyle Ridgway to provide his introduction.
Great, thanks, Tim, and thanks, Michael, for that great introduction and laying the groundwork for us. And of course, thank you to the Alumni Association, the CUPT program, and all the attendees for coming. It's a real honor and a privilege to be able to speak with you and share my experience and interact with the panel members. So, as Tim mentioned, my name is Kyle Ridgway. I'm a physical therapy clinical specialist at University of Colorado Hospital, and I'm board certified in cardiovascular and pulmonary physical therapy. Prior to the pandemic, I've spent most of my clinical career specializing in acute care physical therapy and really subspecializing in ICU physical therapy, and have participated in a variety of clinical programs, training of both entry-level students and post-professionals in critical care physical therapy, and have also had the privilege to assist with or be involved in research surrounding physical therapy and acute care, and specifically ICUs, as well as outcomes after critical illness. And so that's really the passion of mine. During the pandemic, I was actually one of the co-coordinators of our acute care interdisciplinary rehabilitation team and was the PT lead for our COVID team within the hospital, which afforded me a lot of opportunities, which we'll get into. So that's kind of a brief about me, and I'll keep it that brief.
Great, thanks, Kyle. Next, we will hear from our next panelist, Michael Horsfield.
Thanks, Tim. Again, it's a pleasure. Thanks for the invitation. You guys are too kind to invite a Hawkeye into your Colorado experience here, and I really appreciate you sending me the 8 inches of snow last night we had in Iowa to make me really feel at home here. So again, my name is Mike Horsfield. I'm the president and CEO of Rock Valley Physical Therapy. We have 50 locations throughout Iowa and Illinois, and I'm also the president of the American Physical Therapy Private Practice Section. I'm co-founder of a mastermind group called Peer to Peer, which we have over 130 CEOs across the country participate. And so what I bring to the conversation today is really both the clinical pivot that occurred in the outpatient arena in private practice, as well as the business implications of that. And so that's what I'll share with you today. So again, thanks for the invitation.
Thank you, Mike. Next, we'll hear from Dr. Alan Lee.
Thanks, Tim, and thank you, panelists. Again, I want to thank the CU alumni and the CU program for inviting me to speak with you. I'm coming from California, so no snow here, but a lot of rain last night. So with that, I think, you know, I'm a professor at Mount St. Mary's University in Los Angeles. I also practice at Scripps Mercy Hospital. It's a trauma center in San Diego in acute care as well. And I also function with APTA in terms of the telehealth lead for the first council, which is the Frontiers in Rehab Science and Technology Council, which one of the CU alums organized and developed, Colleen Keegan. So I'm very indebted to Colleen and Steve Wolf and others who have got me along and mentor me in terms of telehealth and telerehab. And I think the reason why you brought me to work and discuss this topic with everyone at the alumni is really focusing on looking at not only now or before COVID, but where are we moving all together in terms of practice, research, and education? And obviously, telehealth is one of the areas that I'll be speaking with all of you, but I look forward to this opportunity to work with everybody in the panel. So thank you.
Great. Thank you, Alan. And lastly, we will bring in Martha Schramm.
Good evening, everyone. Thank you, CU Alumni Association, for inviting me. And what an opportunity to be on this panel, and share our experiences through this very challenging, but I think that is presenting us with great opportunity moving forward. And I know we'll all be addressing that here in the next several minutes. I'm a proud graduate of the University of Colorado Physical Therapy Program, and I am president and CEO of Aegis Therapies. Aegis Therapies is an organization that is focused on rehab and wellness services for older adults across the entire post-acute spectrum. So home, adult daycare, senior living, independent living, assisted living, skilled nursing facilities. And while we started the company 20 years ago, the past 8 years, our priority has really been on developing and providing an integrated and transitional model of care for seniors, regardless of the setting. I also serve as president of the National Association in Support of Long-Term Care, a national advocacy organization based out of Washington, D.C., and serve on the advisory council of the International Council on Active Aging. The scope of our practices is across 1,200 locations across the United States and in 37 states. So again, really appreciate this opportunity to share the panel with Mike and with Alan and with Kyle. So thank you.
Great. I certainly share those sentiments too as well, Martha. I think we are thrilled to have you all as panelists and are looking forward to getting each one of your unique perspectives, especially as we sort of dive into a lot of this Q&A. But to start off with, we're going to move a lot into thinking through sort of how treatments are being provided now and looking forward. But in order to truly do that, we probably need to start with where we came from. So the first question, and I'll have you start, Kyle, it's how did COVID first present within your respective environment? And what were some of the immediate challenges that you were faced with?
Yeah, I'll even back it up just a step before that. And, actually just first learning about COVID, I actually remember going on the coronavirus tracking website like every day before work and kind of seeing what the numbers were around the world, seeing the spread. And then I felt like I was getting a little bit of a glimpse talking to some of my friends and colleagues who actually work and live in and around Manhattan. And were starting to tell me about the surge of patients coming in, the issues with ICU capacity, the issues with PPE, the issues with getting patients who don't have COVID out of the hospital, the issue of getting patients who were diagnosed with COVID out of the hospital, the long ICU stays, lack of staff, kind of all of that stuff. I was hearing about it. And so it's kind of, I think about, I have never lived in hurricane geography, but I think about that hurricane warning, and you're waiting, and you're just waiting for the alarm to go. You're waiting for the buzzer to go. And really kind of my first distinct memory was the planning at our institution, which again, we were kind of lucky because we got to learn from New York and Italy's experiences. We started to drain patients out of the hospital. We shut down elective surgeries. We shut down visitation. And I can remember coming in to our hospital, University of Colorado Hospital, which usually runs over 100% capacity. I mean, that's the norm. Coming in, we're at 65% capacity. All of the cafeterias are basically shut down. There's no visitors, and just walking into work down this eerily quiet hallway and just waiting for, okay, what's going to happen? And so for us, really the first presentation or the first challenge was preparing for COVID patients by addressing the needs of non-COVID patients. which was very interesting, which was trying to get these folks out of the hospital, away from the hospital, and really, quite honestly, almost away from healthcare. Our COVID team initially really talked about get them out, keep them away, optimize everyone who's non-COVID to get out of the hospital and stay away from it. Because we didn't know how infectious is this? Does the PPE work? Are we going to be spreading it to patients like crazy? Are we going to be getting it like crazy? And then after that was kind of the slow trickle and buildup of patients coming in. And kind of the opening for me, which was a real throwback, was we have this old unit that used to be our medical ICU, where I kind of really cut my chops as an ICU therapist. And that had been transitioned to a million different spaces over the years. And ironically, that opened up as the COVID ICU. And then that started to grow. And then we started opening up all these other COVID units. And it was kind of like this, you could feel kind of the swell coming. And then the just admission of a bunch of COVID patients. And then it was just like a frenzy, really, of just hitting the ground running with our COVID team and, feeling like a week was a month or a year. So really for us, for me personally, it was a lot of anticipation and thought and trying to pre-plan, and then all of a sudden just jumping in and saying, really, here we go. We've got these COVID patients, we've got these non-COVID patients, and we've got a lot of work to do. And starting to really figure out how we were going to deliver care and treat this patient population. I think the big challenge initially was what I think is a foundational question for all of us, regardless of our role or practice area, which is what's our role and responsibility generally in this pandemic? And then more specifically, what's our role and responsibility here locally in my practice context in my institution? And really thinking about that in a much broader lens. I mean, none of us have ever gone through a global pandemic, so those principles had to come first. And then it was really looking to what problems are here. So our first challenge was really identifying how we were going to practice and how we could fit in, but also really identifying the other challenges that were facing our institution and figuring out how we were going to mesh into there and how we could uniquely address those issues. So yeah, I think that's kind of the start of it.
Great, yeah. Mike, I'd love to hear what your input is from sort of the private practice side as well.
Yeah, we certainly, not as intimate as Kyle was of being right there on the front lines. And so, as Kyle kind of alluded to too, there was this buildup, and like Kyle, living, being in the Midwest, there's several things that we learned looking at some data as far as impact on businesses. And I'm going to speak in that. I don't want it to sound insensitive, but I'm going to speak as a leader and someone who's really feels this responsibility for the people you work alongside. It's their livelihood and it's their jobs. And then we have our patients and what's our obligation to them. So as Kyle said, you're struggling constantly with these dilemmas in an environment where there is no benchmarks, there's no precedent, there's nothing to go on. And so again, what I relied on a lot during that time was calling my friends in New York and calling them in California, the places where it seemed to be going first. We're blessed in Iowa not to have as many people. And that's what we see in the data is the more remote clinics weren't impacted in the communities initially at first. So we had a chance to learn some lessons. We had to learn them quick. So again, from a leadership response, it went to our monthly meetings turned into twice a day meetings as the information was emerging. And then if I speak honestly, I think in a leader, we had to determine at that point, like, again, risk and reward for everything. Like, people count on us to provide care. And if we don't feel like we're really essential to them, then we shouldn't be delivering that care. Like, that's how I gauge skilled care. If they don't need us, then they shouldn't be in our clinics. And then prioritizing the safety and all the fear amongst your team, and how do you balance those things? And so we had periods where it was shut down, where it was only post-surgical patients for a while, and we just wanted to see them. And then you've got some more chronic conditions where it starts to add up, and you got to add in. So that was the initial response, and I can tell you it was as a leader where you're looking at, you have many customers, you have our communities, you have the patients we serve, you have your coworkers. It was really a balancing act. And so that was the initial impact, along with, at the same time, you're a human being. And I think that's for all of us to appreciate. My daughter was in Spain studying abroad. And so you're dealing with that. How am I going to get her home and what's going to happen? So I think that was, for all of us, that was the moment that I'm not sure if we should hold on to it or whether we want to forget it. I don't know what's the best answer to that question, but it was certainly something that as a leader, I had never experienced before.
Absolutely. Yeah. Alan, sort of from your side, especially coming from that telehealth lens, what did that sort of initial presentation look like? And sort of what were some of those very immediate challenges?
Yes, Tim. I kind of echo what Mike and Kyle has just mentioned in terms of like the initial fear, engage, but engage with risks and benefits. Also safety. We learn in our training, do no harm, right? But also not only do no harm, but could telehealth also be harmful, but also could it be beneficial to some, but not all. So more of a measured approach in a way. And it wasn't just in terms of clinical practice either. So it was really in academia where I work with a lot of students trying to keep them safe, either bringing them back from their clinicals if they're out on clinicals, or trying to figure out, is there an opportunity to continue their clinical so they could graduate with telehealth and some mentorship. So I believe those are things that we try to do and engage, like Mike had just mentioned, engage with others locally, but also, far away to see what's happening, not only with APTA or CAPTI, but also engage with the program. So we're on a kind of more of a move together, like I mentioned earlier, support each other, and let's keep everybody safe. And I think those are things that we thought about initially. Looking back, I mean, I know we love to be hands-on and we love to be together, such as we were at CSM Denver. And I mean, my wife called during that CSM and said, hey, have you heard about this physician who passed away in China, or the dentist? And I was like, what are you talking about? I mean, we have 18,000 people here. But yet I think looking back, that just thinking always about the global community is something that I just wanted to reflect on a little bit for all of us. And there's obviously professional, but also personal sacrifices that we've been dealing with. So I think those are things I want to just make sure that we address, but making sure that we can kind of collectively talk together today.
Absolutely. Finally, Martha, would be interested in your perspectives as well, especially coming from that sort of organizational lens.
Yeah, well, I really appreciated Michael's contextual comments. We service, as I said, a large number of sites, different settings across the country. So all those services are provided by 3,500 people. So unlike Kyle, and I think Michael, you mentioned sort of this slow trickle buildup, it was like a tsunami. In our experience was like a tsunami. It hit hard, it hit fast, especially our clinicians in the Northwest and in Massachusetts. It was fast and furious. And so the initial leadership mandate, of course, was how do we keep our patients safe and how do we keep our staff safe? And the context of this idea of being essential, I've been practicing for a long time. And I never really thought there would be a day when somebody would just turn off therapy. And that happened in several instances. The immediate reaction to keeping this frail, vulnerable population of seniors that we care for, one of the immediate reactions was, nobody's coming in this building. We're shutting off therapy. And so for the clinicians to work very quickly to try to ensure that the patients under their care were going to have some kind of alternative was a huge challenge. So the access to care was cut off very dramatically. And the experience, and I think everybody's said this in different ways, everybody was experiencing anxiety, fear for their own safety, their children, their parents, their patients, and to support that with so little warning. For us, the scarcity of PPE was dramatic. Certainly in our outpatient clinics, we supply all of our own PPE, but not when we're working necessarily with home health agencies and other institutions. And it was terribly frightening to not be able to get into a network of PPE distribution. So there was an immediate need to develop those networks. So I think that magnitude of personal and professional stress that everybody was feeling. And the other maybe somewhat unique aspect for us is that it was very clear, not day one, but certainly by day 14, that we weren't just in the midst of a COVID pandemic. We were in the midst of an isolation pandemic and a deconditioning pandemic. And the population that we serve were so susceptible to the negative impact of both of those that it really informed a much broader response plan.
Absolutely. Thank you for that, Martha. So now that we know where we came from, let's kind of move to current. And I want to hear from each one. What were some of the significant adaptations that have been made to meet those sort of initial challenges? And especially kind of give me some of the ones that have been especially successful. So we'll start with you again, Kyle.
So one of the benefits working in the hospital and working with this patient population is we've kind of had this constant adaptation over time, and we've got to kind of improve our quality or what we're doing really, especially initially, hour by hour, day by day, and adapt to the current and match the current situations and demands. And I really think the adaptation that we made initially that laid the foundation for our success, which is not specific, but I think is important, was really actually taking a step back and slowing down to speed up. And what I mean by that is everyone else in the hospital was on hyperdrive, and that bled into everywhere. But we had the opportunity to actually slow down and say, well, hold on, wait a second. Okay, who should we see? Why should we see them? When should we see them? How should we see them? How should we approach this? And I really think the adaptation that we took was the situation forced us to ask the right questions. And by asking those right questions, we were able to take in new and novel information or take in changing information and make these small, subtle changes. But I think the biggest adaptation that we made was by really focusing in a very vigilant way on what we were doing and why. Because we had to ask ourselves in the beginning, the unknowns were, are we going to have enough PPE? We have enough right now. Are we going to get to a point that we don't? Are we going to get to a point where therapists are maybe not deemed essential all the time? And so we'll only have a certain ration of PPE for our entire day. Are a lot of our staff members going to get sick? Are a lot of our patients going to get sick? How are we going to deal with those issues? And so what we did is we were very judicious about who we saw, when we saw them, what we were doing, and really what is our dosage and approach to care. And those are hard questions. I'm not going to pretend that those are conversations, especially your clinicians like to have. If you're an administrator, if you're a leader, if you're a manager, if you're more on the operations side, those are of course questions that you're thinking about all the time. Clinicians don't like those questions, rightfully so, right? And that was part of my role, was to be a little bit antagonistic and say, well, why are we seeing this patient and not this patient? Well, why do we get into this patient's case early? Why do we get on this patient's case late? And those were really, really, really good conversations because A, we got a lot of perspective. but B, we took the time to really focus on the patient population. And what that really resulted in us doing was, number one, recognizing what's novel is not always new. And what I mean by that is the pandemic is extremely novel. The coronavirus is obviously extremely novel in human beings. But if we stripped that away, we've treated patients on airborne precautions before. That's not new. The scale is new, right? I'm not used to having essentially 4 medical ICUs and 3 post-ICU floors in our hospital, but okay, that's not new. Well, wait a second, these patients have really long ICU stays. We know a lot about post-intensive care syndrome. We know a lot about the acute problems surrounding hospitalization and intensive care, especially mechanical ventilation. Wait a second, we've done this before. We did a medical ICU PT program. Okay, let's use some of that information. So really, I think the 2 big adaptations were asking questions and using what we already knew and really laying that on top of what was going on. But some of the undercurrent to that also is we recognize that we have a really big role here, but it's different and it's not exactly always what we think about. And so the last adaptation that I'd mentioned for a minute or two is broadening what we look at as our role as physical therapists. And my thought is, or my bias is as much as we don't like to admit it, physical therapists are much more like surgeons than we care to admit. We like to do things to people. We like to be interventionalists. We are interventionalists in our heart of hearts. And that our training breeds that, what we do breeds that. And it's not bad. But it can sometimes be hard for us to say, wait a second, my role in this case or my role in this pandemic is not necessarily right there with the patient. How do I inform throughput? How do I inform the administrative discussion of how to get COVID patients out of the hospital? How do I inform how we're going to assess oxygen needs for this patient population, which is something that we got very involved in. So that last adaptation was really broadening our consideration of how do we fit our expertise, our experience, our contributions into this puzzle away from the bedside. And I would say where our successes were slowing down and ensuring that we operationalize things in the right way, but not too quickly. Number 2 was asking the right questions and really thinking about who needed us and who we could move the needle on. And lastly was the broadening of that role. We were very successful, and I will say very lucky at our institution that we were in the conversations about treating these patients right off the bat. Some physicians were very surprised, like, oh my gosh, you guys can treat these patients. You can use the PP, that's awesome. But they also involved us. We were a part of making the critical care rounding tool that our medical ICU attending physicians and nurse educator made that went on the door of every ICU patient. We were a part of making the checklist for when and when not to consult therapy. We were in administrative meetings about the flow charts for discharging patients from the hospitals. We were contributing to nurse education on oxygen titration at rest and with activity, because we had cardiac ICU nurses taking care of really medical ICU patients. We had orthopedic floor nurses taking care of pulmonary post-ICU patients. And we really found a role educating the other disciplines and contributing to patient management that way and had huge success. The last success we had was absolutely clinically. We talked a lot early in the pandemic about what we called rehab waves. So, you have waves of infection, followed by waves of hospitalization, followed by waves of death. But for the ones that survive, they have more often than not rehabilitation problems. And that's really where our role and our expertise got highlighted, that we get these surge of admissions. Some people die, unfortunately, but the ones who live, everyone now realizes, wait, this is a rehab problem. Where's therapy? Let's talk to therapy. And the last big success we had was we were really instrumental in helping our physical medicine and rehab colleagues open a COVID-specific acute rehab unit after our acute rehab shut down. And we're in process of analyzing our first 30 admissions of that, and the results were remarkable. So yeah, I could speak for hours, but I don't want to cut into the other panelists' time there.
Yeah. Thank you, Kyle. No, that's really insightful, and obviously, yeah, you've had a wide array of experiences within that. Mike, I'd like to sort of pass it on to you and sort of get your perspective within that private practice environment.
Yeah, thank you, Tim. And if I could, Tim, could I ask that I don't follow Kyle next time? Can you change up the order here? And Kyle, you can certainly talk forever. I'm really enjoying that. Thank you for that. And if I could comment one more thing on Kyle. Kyle, I don't think you got lucky. I think you earned that right to be in that place of making decisions. And I think that's something all of our professionals on hopefully this call tonight will appreciate, is we need to have people like Kyle involved in those decisions. You earn that through small interactions over time. But I'll go back to, I'm gonna approach this, Tim, kind of try to hit some real high points here of what lessons learned and kind of where we're at this point. If I look at from the private practice section, I was not on the board at that time. I got elected during COVID. But the board at that time was amazing, as they realized, again, from an organization standpoint, association standpoint, they weren't built to handle the constant changing information and the members' needs at that time. So they formed a COVID task force, which I was fortunate to be asked to serve on. And so I think the lesson learned in an association right there was get the right people in the room. They got a really diverse group of people that had all different perspectives from private practice. And we were able to sit on a call and solve problems, and the next day get information out to members in a very timely manner. So I know a lot of us in private practice counted on that information, relied on that information, helped it. So from an association section, I loved seeing that. As a private practitioner, again, things we've learned that I think are looking at carrying forward. I'm a big data guy. And when we mined the data or dug deep into it of the practices that came kind of out, everybody, was safe at first for their patient's sake, getting the information, but the recovery curve, what we realized there is those therapists in the communities who had real relationships with their customers, where we use the term relevant. Like, these patients call you and say, hey, what kind of exercise equipment should I buy? I'm thinking about a new pair of shoes. You are their person. Those practices that had direct to consumer, a lot of direct access, people counted on, those practices came out of it really quickly. The other ones that counted on more the referral, that we more called downstream, waiting for that patient to walk in the door, had a much harder time recovering. And some of those still aren't recovered fully, practices that are more designed that way. The other thing, what Kyle said about the ability to elevate up and practice at a higher point of our license, the role we found in the outpatient area was, again, the primary care doctors were worried now more than ever about taking care of sick people. So what we did there is we reached out and said, hey, let us take care of the people that hurt, right? I know we do much more of that as physical therapists, but if we try to simplify that into what we can help take off their plate, give us those patients. Let us get those out of your office so that you can safely take care of the people who really need you during this time. So again, that was an idea. This primary care physical therapist really stepped up. And again, that's something we need to continue to maintain and improve upon as we go forward, to be recognized in that light, just like Kyle said his team was recognized in a different light with that. I know we got some students on there. So again, what we were able to pivot during this time with the need for clinicals to take actually more students safely. We did that through a hybrid of telehealth, as well as we engage them in professional development. So again, a lesson we learned as an organization is we can learn faster via this media. And so we doubled down on professional development, and then we included the students in that. So now the students would come in and they'd have some professional development that would be structured, that they'd go along with our current therapists. They had a telehealth version, and then they had their traditional clinic time. So we're able to decrease the number of bodies in the clinic, maintain a safe environment, but yet increase the number of clinical settings. That's something I don't want that to go away, because the students, we measure that afterwards. It was raving reviews about that kind of that hybrid clinical context. So again, those are just a couple. I've got a few others, but I want to heed the time to the other members. We can take it through Q&A if people have that.
Definitely. Alan, yeah, would love to hear your thoughts, especially since sort of Mike brought in the telehealth side.
Sure. I think what we learned right away is that we learned that our alumni, our students, matter all the time. I mean, obviously quick and nimble and transparent response that we share either with the student outreach committee, if they're in clinicals or obviously staying home because of COVID and getting on Zoom, as well as our alumni who reached out to our faculty to learn about telehealth practice. And I think one lesson that I would take away for all of us is, for example, trying to figure out what is same versus what is different via telehealth. For example, here's my work badge. You should always show your patients who you are and what you're going to be doing with them as a physical therapist, right? And on your patient side, Tim, I would love to see, if you're my patient, who you are, patient identifier, and where you at, because I want to make sure that I'm licensed to practice to treat you where you are. So those things that we informed our students and our alumni, and providing that, I would say, outreach was most important during this period of COVID, but also moving forward. So I'll stop there.
And then Martha, sort of, yeah, broader organizational, and then obviously within your sort of home health experience as well.
Well, getting back to that immediate impact of limited access to patients drove a lot of adaptations that actually have become best practices. So imagine that only one therapist can go into the building on any given day. Our practices have occupational therapy, language pathologists as well. The lack of formal therapy being delivered in some of these sites really drove collaboration to a level that we haven't experienced previously. And we looked to each other to prioritize plans of care and to sequence treatments to make the most of the limited access that we had to patients. Another adaptation, which is a little unique probably across our settings, was to refresh the acute skills of our clinicians. The acuity level of those in our care went up dramatically in many cases. We gathered a lot of great information. Thank you, Kyle, to you and your peers that was coming out of acute care, adapted that for the post-acute space, and communicated that through a daily process with our clinicians. There was also an expansion, a needed expansion, and again, an emerging and best practice to continue in the realm of addressing the behavioral aspects of this disease and what we as physical therapists have to offer in that whole person kind of care. And so made available additional tools like the Hamilton Anxiety Schedule and scale, and embedding those into the practices as we were addressing that second pandemic of isolation. We also adopted telecommunication options, and it allowed us, the remote areas, the rural areas were hit so much harder with this limited access. And so being able to do telesupervision of assistance and really honing the skills of impacting positively virtually, whether that's with the assistant or with the patient. And then finally, we are learning now, and we will continue to learn the sequelae of COVID and what the essential services are that we will provide in the post-acute settings. We've established some recovery units in places like ALFs and SNFs. And so tremendous ongoing learning there as well.
Definitely. And you brought up the sequelae, and I want to sort of touch on another question that I think kind of relates to that, but I want to just hear from the panelists your thoughts on how we transition patients from hospitalization to really any other sort of facility, sort of aftercare facility, and specifically those patients that have COVID, and sort of what special considerations do the PTs need to sort of take into account when treating these post-COVID patients? And I'll start with you, Kyle. Sorry, Mike.
It's a great question. And it's a question that I think was there even before COVID. And I think the way I'll tackle that is, what are issues and problems that were here before that COVID has highlighted? And then what's unique about COVID? And I think we've known, and we do know, through work that Jen Stevens-Lapsley has done, as well as some of her former PhD students, such as Jason Falvey, that care transitions are a point of failure within the healthcare system, and that really physical function is an important piece of that is under-addressed, often not addressed, even at the physical therapist level. I can probably count on my hands the number of times that I've called another setting of care from the acute care hospital to give pass off to specifically to a therapist or to even a setting of care institution about a patient, just because of the bad incentives and the way that our practice is structured in acute care. So there's the logistics around a successful transition, and then there's really the content, I think, around the transition. And I think the undercurrent of the question is, I'm an outpatient therapist. I am treating a patient either primarily post-COVID who is hospitalized, or for something else either related to that or not related to that. What do I need to consider? And as I mentioned previously, all that is novel is not new. COVID is novel as an infection. Viral infections are not new. Viral pneumonias are not new. Acute respiratory distress syndrome is not new. Post-ICU problems are not new. And generally, if I was going to tackle this question to start with, is if you've had a patient who's been in the hospital, especially a patient who's been in the ICU, and more specifically required mechanical ventilation, we know a lot about this. We really do. Generally speaking, the way that we talk about is post-intensive care syndrome. But there's a lot of information out there, and patients deal with a lot, and it's very varied. You could take 6 ICU survivors who all had the same diagnosis, all had the same length of stay, basically had the same treatments, and one may be very strong and have horrendous symptoms and psychological issues and post-traumatic stress. You could have another one who has horrible objective muscle weakness and signs of myopathy and neuropathy. You could have others that have debilitating fatigue that you would see in someone who is receiving treatment for cancer or survived cancer. So the presentations can be so varied. And really what I would say or recommend is use what we know, which is we know a lot about post-intensive care syndrome. We know a lot about issues patients face after hospitalization. So dive into that space and really treat what you see. Use your skills as a physical therapist to figure out what impairments of body structure and function does this patient have? What are their activity limitations? What limitations in participation do they have? What symptoms do they have? What medical conditions do they have? And what do they want to be able to do? I would say the big thing that's difficult for families, difficult for patients, and really difficult for clinicians is critical illness is not a singular event. Hospitalization is not a singular event that you get over. It's not a cold. It's not like, us getting the flu and we're going to recover. This is a whole body, head to toe trauma that is no different than an orthopedic trauma, no different than a stroke. Many of these patients will be changed forever and potentially have impairments forever. That doesn't mean we don't have a role there, but it's knowing that you may not make this person 100% better. I think that's one of the biggest things that I would give to outpatient colleagues. The second is you have a huge role here. After survival, patients talk all the time about trying to get back to where they want to be, trying to thrive, trying to develop resilience. And many of them speak about their therapy experiences and their need for more physical therapy and the benefit of therapy. And so don't undercount your role there. As far as other settings go, I don't think it's all too much different. I think that approach applies to all settings. Yeah, I think I'll leave it at that before we turn this into a 4-hour soapbox lecture from me.
Yeah, thanks. I appreciate that, Kyle. Sorry to
does
interrupt you again, Mike, but yeah, would love to hear your thoughts, especially sort of as you're the next sort of moving from that hospital into maybe a more outpatient facility. What does it look like within that sort of transitionary period?
I think, I mean, I appreciate Kyle's passion and all of his views. I think it's just something we have to be willing to own in an outpatient setting. And I think this is, again, if I get on my soapbox and talk about how this translates us as a profession and COVID has exposed it, is again, is our ability to treat a person and not a shoulder or a knee when it comes into the office. And for us to really have that perspective. We have great discussion around like this. To me, the analogy is like having a customer service department. When we talk about our role in wellness and and function as a whole, we have to see it in that type of context. And a lot of times people say, well, we need a customer service department. I'll say, no, it's all of our job, customer service. If we have a department, we're going to defer it over there. So again, my soapbox as a profession is we can't put this in a box and say it's just over there. It's this division or this section or this group. This is something we as a profession have to own because each of us practice in a certain setting where we will see it in some form. And we have to appreciate and learn what's out there. I know APTA's got their PACER series and working on adapting the information as it evolves. And that's no matter what setting we see patients in, we're going to come across people that have been impacted by this, like any other condition, like Kyle said, and we have to know what our role is, and we have to step up and do that.
Alan, yeah, would love to hear your thoughts, especially moving with sort of integrating more telehealth within there, sort of some of those special considerations.
Sure. Thank you again, Mike and Kyle. I think it's owning it is part of it. But I think prior to pandemic, the consumers did not even know what telemedicine or telehealth was, but they do now. And so when we say we're going to own, physical therapy and help, post-COVID and patients with, considerable needs for physical therapy, we may have to kind of reframe ourselves and think about how do we collaborate with other telemedicine or telehealth PTs if we're not comfortable doing it. I know in some of the earlier questions that were posted in registration included students who don't want to do telehealth and also fear that. And that's fine. I think we have to own that too. But also some of the champions in telemedicine and telehealth at the HHS believe that moving forward, 10 to 30% of practice from medicine to all healthcare could be done via telehealth for the consumers at the right time, right place. So therefore, we have to own that based on education, based on practice with mentors, and also with others within your practice who are champions. And lastly, with education and research, which is really based on evidence. So at Vanderbilt, for example, they learned during this pandemic that they can't do telehealth PT with everyone, but they're getting really strong outcomes and successes with patients who are very satisfied when you're treating facial impairments, such as Bell's palsy, via telehealth. So perhaps trying to figure out, one, where are the access issues in your workflow? Two, how do I improve that access issue for your patients and clients and get those outcomes via telehealth? So I think that's important to consider. So I'll stop there.
And then Martha, yeah, thinking about especially your patient population as they're transitioning from a hospital care, what are some of your thoughts on how to sort of best practices for that?
Is my video on? Is it okay? I think I really appreciated, Kyle, you commenting on the handoff. Something that is experienced in the post-acute setting way before COVID. So when we talk about what's new or what's not new, and I think that we need to keep working on this. I think that the losses incurred when we have redundancies in handoffs are often very significant. And so I'm not sure I know what all the solutions are, but I do know that the exigency of this pandemic has forced an awareness that I think is moving us forward. Also, back to the notion of the whole patient, and as I think Kyle was also commenting, the sequelae of this of COVID is manifested in so many ways and in so many degrees of intensity. And so the challenge, I think, for us as physical therapists and in our practices is to ensure that those arenas of cognition, again, of anxiety, of depression, that we are skilled and that we are diligent in making sure that as we transition these individuals to whatever their definition is of wellness, that we have embraced that, we have embraced the evidence, and we've put it into practice. I also would comment that to some of Alan's points, what is the best use of telehealth? It is a touch factor with these individuals that we need to really take advantage of. And especially what we're seeing is in home health is to ensure that we have an extended period of time to have that touch point and to be able to better influence maybe some of the subtle signs of decline during this period of long recovery. So there's much for us to keep learning around that. And I agree, right now, our percent of visits that are telehealth are less than 1%. I don't know what the right percent is, but we need to challenge ourselves that we're using it in the best way at the best time with the right people.
Great. Yeah, I appreciate all of your all perspectives on that. One more question. We're certainly coming up on sort of the last 15 minutes here, and I want to save time to sort of go over a couple of last points. I want to sort of hear, where would you each advocate for sort of changes in PT practice now? And has some of that changed since we've sort of gone through sort of our pandemic period here? And I'll start with you here, Mike, first.
Well, now you're going to give me the hard question. I was going to copy off Kyle again. There's so many opportunities. And again, I think during a crisis like this, Martha replied to it and Michael started off, is you see the cracks, right? And so again, if I look at from a professional standpoint, I'm going to talk of the organization, private practice, and what sections and associations can do, is I do think we need to be more responsive and more timely and give people more applicable information that they can utilize right away. I also believe, again, the interconnection between what this pandemic brought us as a profession was it brought us together. It appears as if during good times, people like to have more disagreements than they do during difficult times. We're united around a common cause. And I'm hopeful that collaboration will continue, that it's not my turf or your turf or our turf. And again, we talked a little bit about, we're here to serve our patients, and the patients cross all of our sections and associations and academia and private practice and all the artificial fissures and barriers and things that were there just seemed to go away during this time. And we're all like, how can we help you? And people were looking externally to help others rather than worrying about what was theirs and what they should own. I really hope that is something that we learn as a profession, because I'm not a finite pie kind of person. I believe we should work to grow the pie, and if we do, there's going to be plenty of it for all of us. And it's really going to be about how do we continue to serve the people that would benefit from the services we provide. So that's a big global professional viewpoint. Again, I think where I really look at the outpatient setting, what do I hope changes and continues to change, goes back to that elevation in the public awareness that we are primary care and that we can help take care of you for this, and that our fellow medical professionals see us as those people who can help them focus on what is most important at that time for them. And we call it practicing at the top of your license, but I think that's something as therapists that we have to really be in the patient management business. And Kyle, your point about we're more like surgeons really resonated with me, because I believe there'll be a point in time where we get paid more for our mind than we do our hands, and that ties to what Alan is talking about. Via what can we manage via telehealth. But I think those are the things I see that we became aware of during this time, and that I hope continue for the indefinite future.
Alan, same question for you, sort of specifically looking at sort of that advocacy piece again of what are you sort of feeling in terms of advocating for within our professions? Has that changed since we've gone through this pandemic?
Yeah, I mean, I'm gonna echo what Mike said, and I think we're like literally right at the hour mark. So probably like a good stretch for everybody would be a good thing. Like everybody should kind of do a hands up and let's go together and let's advocate together. And I know all of you who's on this call do that already, right? And students, your professors encourage you to be part of APTA and also advocate at the state level. I mean, that's something that I learned that really had an impact during this time period, is that we must work together, not in silos, as Mike said. I mean, PPS was working with HPA, where I work with the TechSig. APTA was developing resources and guides for telehealth, very quick, very nimble, but also working with acute care and thinking about patients with COVID with the PACER program. So I think that collaboration, really is the key moving forward, that we don't lose that as we kind of, hopefully with vaccinations and moving forward, that as we celebrate this centennial, that it is not different academies and sections, but we could all lean on each other to be better. So.
Thanks. Yeah. And then Martha, same question, sort of thinking about that advocacy piece again.
I'm going to springboard from that just a little bit. I think that we learned through this that if we don't advocate for the essential, that our services are essential, it can be quite fragile. But where I want to pivot to is within our profession, that advocacy, but the value of advocating with our rehabilitative professional partners. So AOTA and ASHA, and how do we together have a louder, more effective voice on the essential nature of rehabilitation services, I think is an important part of this.
And then finally, Kyle, go ahead and finish off, especially just focusing on this advocacy piece.
You're letting me end. Dangerous move there, Tim.
Question, so don't go too long here.
I mean, I think for me, what really became hyper focused during all this, and what I'd like to see happen is going back again to asking the right questions and really asking ourselves generally as a profession, but in specific settings and specific clinics and specific institutions that all have different local contexts, is really what is our role and contribution, and sitting with that question, because I think there's ways for us to expand what I would say is the reach and the impact of a single physical therapist or physical therapy generally. And really, for me, thinking about who's not going to do well without us and who really needs us. Because we're always going to have a prioritization problem, which, in acute care, we're very familiar with, but we can't treat everyone in this country who would potentially need us. I wish we could. I mean, my outpatient colleagues will quote it better, but I mean, we touch something like less than 1% of all musculoskeletal conditions. How are we going to touch 100%? We don't have the workforce for that. So how are we going to touch those people who are most vulnerable, who really need us? And how are we going to expand the resource of the physical therapist to make impacts throughout healthcare, but also just throughout society? So that's where I'd like to see us go. So it's a simple vision, it's a small vision, but I think we can get there.
And I'm just going to keep you on since this is sort of our last question before we close out here. I just want to hear from the panel, very brief, but sort of what is your sort of major lesson learned, or what do you feel like needs to be the takeaway as we continue moving forward?
Man, kept it simple, of course. I think really at the end of the day, physical therapists and especially our physical therapy clinicians are problem solvers. We are problem solvers, and that can be scaled in an organization in a lot of different ways. And that could be scaled within healthcare in a lot of different ways. But physical therapists, by their training, because of the depth of it, because of the breadth of it, and because of how we operate clinically, we are really good problem solvers. And I think that's been my biggest takeaway and the biggest encouragement for me is seeing that in action be kind of forced to come to bear, that we've really had to use that skill in acute care, in home health, in SNFs, in acute rehab units, our private practice colleagues. I mean, everything you've heard here is PTs being problem solvers. And, there's been a lot of talk about advocacy and reaching out. So the other thing that I think I've learned is we got to collaborate. We got to play nice in the sandbox, and we have to be open to different roles and different relationships with all kinds of folks throughout healthcare, from administrators to physicians, because there's just untapped opportunity across the healthcare system. And that's even me with my very narrow experience within the hospital. I'm sure in the outpatient space, the home health space, it's even bigger. So I think I'll leave it in that.
Alan, Mike, Martha, I'll let you guys kind of comment on your sort of final thoughts.
Okay, so I'll follow since Mike told me that it'd be best to follow after Kyle. And so I think really where I started, how do I help CU and CU alumni? Really, we're all lifelong learners. So if you look at like what's been developed, so APTA has developed education. There's a new telehealth certificate program. Certain states going to require telehealth PTs to be educated to provide that telehealth service, such as state of Washington with their board language now. So know your practice acts, but also continues to develop your skill sets. And I think that's when you lean on your program, such as your esteemed faculty and your colleagues, your alumni, and just work together. And again, it's not for everybody. These are touch points, like Martha said, but figure out where it's gonna work best and where it's not. And again, like I said, do no harm.
I'll just comment that I think a real opportunity for us as we move forward is to keep learning for sure, but and I'm sure everybody has in one way or another been collecting data and trying to understand the impact of all these adjustments and perhaps new use of our skills during this time. I think the opportunity moving forward is to challenge ourselves what these best practices really are and how do we best apply them moving forward. And I think everybody's touched on that. There's best practices in collaboration. It's not all the manual gift that we have with our patients. So I think now we have an opportunity to step back and to be very purposeful about just where are those best practices and how do we take them forward?
Those are great. And I think, Tim, if I try to be brief in the what have I learned, I think if I would summarize it, it's great things come when you say, I don't know, and I'm afraid. I never thought those would be strengths or signs of strength. And so, as a leader, sometimes you're told you shouldn't say those things or you can't. But what I've taken away, I think, as a profession is when you get a bunch of people around who you can be vulnerable with. And in a time like this where no one knows the answers, you learn a lot. And it takes me back to my student days and the students on the call I will share with this is, and Kyle, it's an offshoot of what you said, is I've learned best from being around a group of just really interested people of inquiry. not people with answers. So surround yourself with people who have better questions than you, and you will learn more than people who have better answers than you. And so I think that is one of the things I've evolved more than I ever could imagine, because this time has forced me to surround myself with more people. And it goes to that, again, simple thing Dr. Dunn has been preaching to us since she started as president of our association, is we're better together. And this was a great excuse to be together, but let's find more reasons to be together as we move forward to answer difficult questions that impact people's lives with people we enjoy doing it with. And that's how, as a profession, we will move this thing forward.
That was a great wrap up right there, Mike. And certainly the four of you are people that have far more answers than I have, and probably better questions too. So it's certainly appreciate you all sort of taking the time to answer some of these questions. I appreciate everybody in attendance. It's amazing how quickly an hour and 15 minutes can go by. I do apologize for any questions that we were not able to get to sort of in the Q&A, but we will plan on giving some follow-up that can probably answer a lot of those questions later on this week. And with that, I will pass the mic off to Andy Levy for some closing statements.
Hi. COVID-19 has presented enormous challenges for all of our personal as well as our professional lives, and no one remains untouched from the impact of this novel coronavirus. Those of us in the healing arts who are unable to remain completely remote are faced with tremendous tasks of providing care for our patients, as well as maintaining a safe environment for ourselves, our patients, and our staff. This is an evolving struggle as we learn more about this coronavirus daily. We hope the experience and the innovations that are described by our panelists have been helpful to you in your daily practice of physical therapy. I'd particularly like to acknowledge and thank Colleen Keegan, the immediate past chair of the CUPT Scholarship Endowment Board, and Tim Lohr, president of the CUPT Alumni Association, for spearheading this program. To Natalie Iannicello, the communications relations professional from the physical therapy program, who provided invaluable support in coordinating all of this and in the efforts of putting on this webinar, and Noel Rodriguez for all the technical support. Also need to acknowledge and thank Dr. Michael Harris-Love, the program director and associate dean of the PT program at CU, for his insights and assistance. And of course, a special thanks to our panelists who have volunteered in this effort, providing their time and knowledge for our benefit: Mike Horsfield, Alan Lee, Kyle Ridgway, and Martha Schramm. Thank you for all of your insights. We hope to bring more programs like this to our alumni and our friends and other professionals. A survey, as Tim had mentioned, will be sent out to you in the upcoming days, and it'll include an opportunity for you to submit follow-up questions and comments. We want to thank all of the partook in this presentation, and wish all of you health, safety, and a good evening. Thank you.